Hey there, class. Welcome back. We are in week 11, and this is our last week before finals. This week, you are going to be working on your coding capstone. So, chapter 20 and chapter 21 focus on preparing you for that coding capstone. It's very self explanatory. I want you to pay attention to what we review in chapter 20. And then for chapter 21 with the coding capstone guidelines, basically what you're going to do is you're going to read through some cases and you are going to code them to the highest level of specificity. Some of those cases might have only one code, while others may have five or six. So it's really important that you capture everything you need to capture. Um, and if you have any questions, please feel free to post them on the discussion board, um, and I will get to them. But for now, we are only doing the lecture on chapter 20, and then chapter 21 is the capstone. So in this chapter, basically, I'm shifting over from the outpatient focus into the inpatient coding world. We're still going to use ICD-10 CM, but the rules and priorities are a little bit different when a patient is admitted to the hospital, and so we kind of talked about this in the beginning of the class with the differences between the outpatient coding guidelines and the inpatient coding guidelines. And for the chapter 20, it's all focused on inpatient coding guidelines. So it's different. So I want you to revisit those inpatient coding guidelines. We refer to a diagnosis not as first listed, but as a principal diagnosis. So we're still going to use those again, those CM codes, but we're going to think about the big picture of a hospital stay. Why was the patient admitted? What happened during the stay? And how that turns into codes that drive data, quality reporting, and payment. By the end of this chapter, you should feel more comfortable with the language and the logic of the inpatient diagnosis coding. So I have 5 main goals for you. First, I want you to be able to tell a difference between concurrent coding, coding while a patient is still in the hospital, and discharge coding. And that happens after the stay is over. Second, you're going to apply those official coding guidelines that are specific to inpatient reporting, including how we treat uncertain diagnosis. Third, you'll learn how to assign POA indicators correctly so we can show which conditions were present on admission, or POA. Fourth, you'll see how DRGs, or diagnostic related groupings, are built from your codes and how they impact hospital payment. Lastly, you'll understand why the UHDDS, the Uniform Hospital Discharge Data Set, is the backbone of inpatient data reporting in the United States. Before we get too deep in the lecture, I want to make sure that we take a look at the vocabulary and this feels familiar to you. So comorbidity is another condition that it's another condition that a patient has in addition to the main problem. It can influence care and outcomes. A complication is a new problem that arises during the stay, often related to treatment or the hospital environment. Concurrent coding means assigning codes while a patient is still in-house or hospitalized instead of waiting until discharge. A DRG is a group that hospitals use for payment. Patients with similar diagnosis and reference or diagnosis and resource get grouped together. A hospital-acquired condition, or a HAC, HAC, is something that the patient did not have on admission but developed in the hospital. MCCs are major complications and comorbidities, and they're the highest severity secondary conditions. POA, present on admission, is a flag that tells us whether the condition existed when the patient was admitted Or, if it wasn't a condition that existed on admission, did it develop during the hospital stay? Like, for example, we may see a pneumonia. Is pneumonia present on admission, or did it develop during the hospital stay? Lastly, UHDDS is a standardized list of data elements that hospitals must collect for every discharge. So I'm going to compare the differences between concurrent coding and discharge coding. I want you to notice the pros and the cons of each. Concurrent coding allows coders to keep up with the documentation during the stay, which can help with queries and early identification of gaps. Discharge coding waits until the stay is complete and uses the full record, especially the discharge summary, to finalize the codes. As we go through this lecture, think about how each approach impacts workload, communication with providers, and the accuracy and timeliness of the data. When we talk about concurrent coding, I want you to picture yourself following a patient's stay in real time or story in real time. I'm reviewing the progress notes, the lab results, imaging reports, the consults when the patient is still in a bed. As the information appears, I update the diagnosis and flag questions for the provider. I may even query the provider. The benefit with concurrent coding is that you capture the documentation issues early. The charts don't pile up untouched. And the challenge is that the story is always evolving, especially if a patient is admitted and there's no definitive diagnosis. Diagnoses change. They can be ruled out or become more specific. So as a concurrent coder, I have to be flexible. I have to be comfortable with ambiguity and ready to revisit my work once the patient is discharged. Once a patient leaves the hospital, certain documents become my best friends and my go-to as a coder. So the first thing I'm going to look for when a patient is discharged is that discharge summary, right? That's where the provider tells the complete story of the stay, why the patient was admitted, what was found, what was uncovered, how did the patient respond to treatment, to therapies, to surgery, whatever happened during that stay. The hospital course section lays out the key events and changes in the condition. Discharge instructions can clarify ongoing conditions and follow-up visits. The discharge disposition tells me where the patient was discharged to. Was it home? Was it a SNF? Was it hospice? Or maybe another hospital? This can influence certain codes and quality measures. If the patient passes away, the death or discharge summary still needs to be coded carefully. I use all these documents together to confirm the principal diagnosis and any additional diagnosis that truly impacted that care. So we're going to revisit those OCG, the official coding guidelines, but with a little bit of a twist, right? We're focusing on how they apply specifically to inpatient care and inpatient coding, but the guidelines define how we pick the principal diagnosis, how we sequence secondary diagnosis, and how we handle uncertain diagnosis in the inpatient setting. I want you to see that hospital coding is not just more codes. It's a different way of applying the same code set. And that's guided by the UHDDS definitions and inpatient-specific rules. As we go through the examples, keep your guidelines handy and practice matching what I say to the actual wording in the book. In inpatient coding, we have a special rule for uncertain diagnosis that can often take students by surprise. If at the time of discharge the provider documents a condition as probable, suspected, likely, questionable, possible, or any other similar terms, and the workup and treatment support that diagnosis, we code that condition as if it exists. This is only for inpatient, it's not outpatient. That means we report the condition itself rather than just the symptoms. This is very, very different. Again, very different from those outpatient coding guidelines. The key things that we look for are what was a provider treating? What did the test focus on? What does the discharge summary emphasize? If everything points toward a diagnosis, I assign that code even if the word still says probable. So, like, for example, if the patient had bacterial pneumonia and the provider in the discharge summary stated that it was probable bacterial pneumonia, responded to um, uh, an antibiotic while given in-house, I would treat that as a bacterial pneumonia. I would code that as a bacterial pneumonia rather. In an outpatient setting, of course, we wouldn't do that. We would code it as the signs and symptoms, of course, depending on what the provider documents. So for the outpatient setting, the clinics, ED visits not resulting in admission, and other outpatient encounters, we do not code those conditions as probable, suspected, questionable, rule out, working diagnosis, etc. And as I mentioned on the previous slide, we want to capture that by highest level of specificity and certainty documented in that visit. And sometimes that just means coding those signs and symptoms, any abnormal test findings, or the reason for the visit. So if the provider writes rule out pneumonia and only documents cough and shortness of breath on that office visit, we're going to code the cough and the shortness of breath, not pneumonia. So I want you to remember the contrast between the two. With the inpatient, code uncertain diagnosis at discharge. The outpatient, stick with what is clearly established. Sometimes a patient is admitted mainly for diagnostic service. For example, a patient is admitted for a complex workup that cannot be done safely as an outpatient. In those cases, I chose the principal diagnosis based on the condition that prompted the test or the main reason for the diagnostic admission. Abnormal findings from tests are not automatically coded. I only report those findings when the provider documents that they were clinically significant. So, for example, when they lead to a new diagnosis, a change in treatment, or additional monitoring. This keeps us from cluttering the claim with incidental findings that did not impact patient care. So now we're going to shift to the POA indicators. And POA, again, is present on admission. So I want you to see that POA is not just one more thing to click, but as a patient safety and payment tool. POA indicators help CMS and other payers distinguish between conditions the patient brought with them and conditions that develop during the hospital stay. That distinction affects the hospital report card, the HAC penalties, and how certain diagnoses are paid. As coders, we're responsible for assigning POA flags that accurately reflect the documentation. So this is a really important skill to build. You don't want to forget to note that POA indicator on the diagnosis. So for the admitting diagnosis, say it was pneumonia and it was POA, you would say yes. You would mark yes in the coding software. If it wasn't present on admission, but it was present upon discharge or it happened during the hospital stay, then you would mark no because it was not present on admission. So when I assign that POA, I use the official definition. A condition is present on admission if it exists at the time the order for inpatient admission is written. This includes conditions that develop during an outpatient encounter, like in the ED, observation, or outpatient surgery. If they are still present when the admission order is placed, if the record clearly shows the condition was there before admission, I would mark the POA as yes. If at first it appears in the progress notes or test results after admission, I consider it not a POA unless the provider explains that it actually started earlier. The timing matters, and sometimes I need to query the provider if the record is unclear. So these are the POA indicators. They're just single characters, but they carry a lot of meaning. Y obviously means yes, the condition was present on admission. No means it wasn't. U means it's unknown, when the documentation is not clear enough for me to tell whether it was present on admission. W means clinically undetermined, which is used when even the provider cannot say for sure whether the condition was present on admission. Finally, number 1 is used for POA exempt codes. This is a diagnosis where a POA indicator is not required. My job is to pick the value that matches the documentation, and when in doubt, I go to the provider for that clarification. A hospital-acquired condition, or a HAC, is any condition that the patient did not have on admission but developed during the hospital stay, often as a complication of care or in the hospital environment. Examples include certain catheter-associated infections, pressure ulcers, or injuries like falls. HACs matters because the payers may reduce or deny additional payment for some of these conditions if they are considered preventable and not present on admission. That's why an accurate POA indicator and careful documentation are critical. Our coding directly impacts whether a condition is treated as a HAC. And a lot of times, if the payer denies payment based on a HAC, the hospital has to write that off. And so the hospital's bottom line suffers for that. Now we're going to move into the world of DRGs, or diagnosis-related groups. In this section, I want you to see how DRGs connect your codes to hospital reimbursement. A DRG is basically a grouping system that puts together patients who have similar clinical characteristics and are expected to use similar resources. Your principal diagnosis, your secondary diagnosis, including CCs and MCCs, procedures, and sometimes other factors like age and discharge status are all used to assign a DRG. Once that DRG is set, it drives a fixed payment for the stay, regardless of the number of days or individual services. When I think about DRG, I imagine a funnel. All of the details that I code, principal diagnosis, secondary diagnosis, POA indicators, procedures, all of that gets funneled into or poured into a grouping algorithm. The DRG that comes out on the other end represents both the clinical story and the resource intensity of that stay. A patient with pneumonia and no significant comorbidities might fall into a lower severity DRG, while a patient with pneumonia plus an MCC, like acute respiratory failure, will fall into a higher severity DRG with higher payment. This is why the quality and completeness of your coding is so important in the hospital setting. And there isn't just one DRG system. That would just be too easy, right? Over time, different versions have been developed to better account for severity and different patient populations. You may see terms like MSDRG, Medicare Severity DRGs, APR DRG, all patient refined DRGs, and other variations designed for long-term care or international use. Each system has its own rules and groupers, but the basic idea is the same. Use diagnosis and procedure codes plus factors like CCs and MCCs to group patients in a way that supports fair payment and comparative data. The principal diagnosis is the anchor of inpatient coding. It's defined by UHDDS. It's the condition that after study is found to be chiefly responsible for the admission. I don't just pick the worst sounding condition or the one listed first in the note. I look at the whole story. admitting notes, test results, hospital course, and of course the discharge summary to decide which condition truly drove the need for the inpatient visit. Once I can identify that, I code it first, and then I add any additional diagnosis that meet reporting criteria and impact the stay. Complications and comorbidities are the supporting cast around the principal diagnosis. A complication is a problem that develops during the hospital stay, often related to treatment or a procedure, for example, bleeding after surgery. A comorbidity is an existing condition like diabetes or heart failure that is not the main reason for the admission but still impacts care, length of stay, or resource use. When I code these accurately, they help paint the fuller picture of how sick the patient was and how complex the care was. In many DRG systems, designated CCs or chief complaints can move a case into higher severity groupings. MCCs, or major complications and comorbidities, are the most impactful secondary conditions. They are serious illnesses or problems that significantly increase the intensity of care. Things like sepsis, acute respiratory failure, or severe malnutrition. When an MCC is documented, actually treated, and correctly coded, it can move a DRG into a much higher severity level, which therefore increases payment to reflect the additional resources the patient required to get well. My responsibility is to make sure the documentation supports the MCC and that I assign the correct codes and the POA indicators for the data and make sure it's accurate. Now we come to UHDDS, which is the Uniform Hospital Discharge Data Set. This section explains where many of our inpatient definitions come from. UHDDS is a standardized list of data elements that acute care facilities must collect and report for each hospital discharge. It's not just about coding, it's about the entire package of data that follows a patient out of the hospital and into statistics. It also goes into quality measures and public health reports. When we talk about principal diagnosis, additional diagnosis, and procedures, we're really applying UHDDS rules in practice. UHDDS includes demographic information, the principal diagnosis, up to a defined number of other diagnoses that impact the stay. All significant procedures, provider identifiers, and information about discharge status. This standardized set allows hospitals, payers, and public health agencies to compare data in a meaningful way. As a coder, I may not see the UHDDS on the screen, but I'm applying it every time I decide whether a condition qualifies as a reportable illness or whether it meets the definition of principal versus secondary and how the procedure should be captured. So to wrap up this chapter, I want you to remember that coding process itself is consistent. We review documentation, we identify the diagnosis, we assign ICD-10-CM codes using those official coding guidelines. What changes from the outpatient to the inpatient setting are the rules and the definitions that surround those codes. UHDDS definitions and principal and secondary diagnosis, inpatient rules for uncertain diagnosis, POA indicators, DRGs, HACs. All of those criteria help us with the decision-making process with inpatient coding guidelines. When you combine strong coding fundamentals with a solid understanding of these inpatient concepts, you become much more versatile as a coder and can move comfortably between outpatient and hospital environments. And that wraps up our chapter. So if you have any questions, please post them on the discussion board and have a great week. Have fun with your coding capstone. I know you're going to do great. You guys are all rock stars. And reach out if you have any questions. All right. Take care. Bye-bye.